So, this session will be recorded, and in next 2 minutes, I think we can start the session. I'll just wait for 2 to 3 minutes for more people to join. So around, I think 10:03, we will be good to start. Everyone, just to let you guys know that this session will be recorded, and thank you very much for joining today's session. I'm Dr. Sana Umar, and I have recently cleared all my Canadian exams. And today's class has two parts. First part is NAC OSCE oriented counseling, and it is in relation to the topic that we started in the last class. And the second half would be a brief review of a topic from psychiatry, which some of you requested me to discuss in the class. So there will be two parts of the meeting. So share the screen now. Okay. So this is the today's objective and agenda, as I mentioned, that you will gain insights from my recent success in NAC OSCE and MCQE1. And a little brief introduction about me. So I am an IMG just like you guys, and I have been doing my Canadian exam since 2021. Since then, it has been a bittersweet journey. From last 1 year, I have been working as a volunteer physician assistant with some of the family physicians here in Alberta, Calgary. And other than that, I'm a part of some of the volunteer organizations. Now, I have some teaching experience from back home as well of teaching undergraduate students. 2 years back, I had the chance to meet the Health Minister of Alberta, Mr. Jason Copings, and I was able to present the problems which are being faced by IMGs, like lack in number of seats and the exam fees and all those things. And that gave me the idea to engage with the broader audience, and that is the reason that I started this entire journey of sorry, let me enter a few people here. Okay, so that is the reason that encouraged me to start this journey of NAC OSCE. So some of you who were a part of the last class, they must be knowing that we were discussing the topic of chest pain. And before that, I will just give you a brief review about what is NAC. So NAC is, it's called National Assessment Collaboration Exam. And the reason that it's called National Assessment Collaboration is because it is the day that entire Canada, all the students who are appearing from the entire Canada, they are appearing in the same exam. The set of questions is the same on that same day, on that particular date. So that means, what does that mean now? That means that you are competing against the entire set of your fellow students on the same day, and you have to stand out in a way because all of you are having the same question answer sets, and the person who's going before you and the person who's coming after you will be having the same set of questions to be answered. So what you need to do in order to stand out and to be different and have a high score. So this is what NAC is all about. NAC is not a very theoretical thing like QE1. It is more of your soft skills. It is more related to your interaction with the patient. So it is an assessment of your ethics and your communication skills, that how by living in the Canadian system, how will you interact with the patient? And that is something that we as IMGs lack because we don't have that training from back home to that extent. We do interact with the patient, but it is different the way it is done here. So that is the reason that this NAC exam is introduced. So it's a half-day examination, 3 to 4 hours. And as we all know that there are 12 stations, 2 of them are pilot stations. 10 of pilot stations mean that your performance on those 2 stations will not contribute towards your final score. But at the same time, you don't know that what 2 of those pilot stations are. They are just anonymous. So 10 stations are there and you get 11 minutes for each station. Now, what does that mean? That means that you will have some set of questions outside the room. And then inside the room, you will get almost 8 minutes to, talk to the patient and take the history or counseling, whatever your task is. And some of the stations will then have 3 minutes of post-encounter. So the 2 minutes that you get outside the room, like outside the door, I don't even call it 2 minutes. I call it like 1.5 minutes. The reason is that 30 seconds are just wasted when you are walking from one door to the other and in reading the statement and all that. So in the last class, I discussed that what questions of NAC look like. So this is a brief review. You can, in my view, you can have almost four types of questions outside on the room door. It can be history and physical examination, it can be history and counseling station, it can be history only, or it can be examination only. Examination only is very rarely heard of, unless it's a cranial nerve examination, because it's a long examination, so the entire station is dedicated to that. Other than that, most of the stations will be history and physical and a post-encounter, or history and counseling and a post-encounter, or without a post-encounter. The main focus of my course would be on the counseling stations, and the reason is that I feel that counseling stations are the stations that can actually give you a chance to score higher than the other students, because physical examination, everybody will be doing the same steps. Everybody knows how to palpate and percuss and do all that. But when it comes to counseling, everyone has a different style of doing that. So counseling actually brings out the doctor in you, the physician in you, and how you interact with the patient. How are you able to dig into the history? In my exam, I had 4 counseling stations. So you can well imagine that how important good counseling skills are. And in some of the stations, you might even be asked that, how you will summarize your history with the patient. So considering all this, I feel that counseling is something that IMGs really struggle with. And this is the main area where I can actually help them, apart from the main course of the NAC OSCE. So as I mentioned earlier, this is the time division. I don't call it 2 minutes outside the door. I say 1.5 minutes, because in that 1.5 minutes, you have to read the statement and you have to make your template. My tip for this one is that, once you read the statement quickly on a side of your notebook, write your task, whatever your task is, that it's a history and counseling, or is it history and physical, because it is very likely that you go inside the room and under the pressure of time and exam pressure and performance and everything, you just forget that what your task is. So rather than wasting your time in reading the question again, it's better you write on your notebook quickly that, okay, my task is to, do history and counseling or history examination, so that you're focused and you know your time well. So other than that, in that 1.5 minute outside the room, you will write your basic history template and you will make a list of your differential diagnosis, so that you are clear in your goal that once you enter the room, what are you supposed to do? How are you going to take your patient and the examiner along with you, along with your thought process? So that thought process, you have to, think about it, and you have to write things and comprehend them in those 1.5 minutes outside the door. Now, last time we discussed a scenario of chest pain in the last class, and we discussed that if this is a scenario that a 40-year-old male non-smoker comes to emergency with the chest pain, address his concerns. Okay, so we together we made a list of differential diagnoses. This was, I gave took 1.5 minutes, and I told the students that make a list of their differential diagnosis and write their basic template of the history. Then it was told that how, they need to address the patient, introduce yourself, sanitize your hands, all those steps. And then we discussed how do we make a list of differential diagnosis. Those of you who are attending the session for the first time, I use the mnemonic SPIT to make a list of differential diagnosis. That means that your list of differential diagnosis, especially when it comes to NAC OSCE, it should have some serious diagnosis, some probable diagnosis, some interesting or rare ones, and some testable or treatable ones. So now considering the chest pain scenario, if any one of you is joining the class for the first time today, would you like to, make a list of your differential diagnosis? You can even write it in the chat box, or you can just raise your hand and you can share your list. So we can take like 30 seconds for this, and then we'll move on to the next slide because we did this in the last class as well. So this will give you an idea that how your list of differentials should be. Okay. So now moving on to the next slide. So this is the list of differentials that I made. Now, the reason is that there are a few things that you cannot miss in your differential diagnosis, and those are the life-threatening conditions. For example, aortic dissection, pulmonary embolism. You do need to have that in the list, and the reason is that the examiner needs to see that you are a safe doctor. You are not going to kill the patient. So the dangerous things should always be on the top of your mind. Other than that, how you make the list of differential diagnosis in NAC OSCE is that you always have to address the same system. For example, this is a chest pain scenario. So you take two differential diagnoses from the cardiovascular system. And other than that, you check for the adjacent systems. So what is the next system after next to the cardiovascular system? Is the respiratory system. So you need to have some differential diagnosis from that area. Pneumothorax, pneumonia. Other than that, think of the next system which is adjacent to the cardiovascular system. It is your GI tract. So what will you think from the GI tract? It can be GIRD, it can be a ruptured esophagus. Everything can present with the chest pain. Just to make it more interesting, if you can add another system to this scenario, it will be a jackpot. So adding herpes zoster, maybe it's just a rash, or maybe a musculoskeletal system like costochondritis. So, or maybe if the patient is a drug user, IV drug user, or a young patient coming with chest pain, so cocaine, because it's very common. So all these things, this is how you will make a very concise and targeted and good list of differential diagnosis. So your list of differential diagnosis should have all those points. Now, this is the basic history layout that we discussed last time. You have introduction, then you go for chief complaints, medical, family history, social history, and the wrap-up. So the two most important parts of your of your NAC OSCE station when it comes to your marks are your introduction and your wrap-up. And the reason is that the introduction will set up the bar for you that, okay, this is the doctor who's in the room, this is the physician in the room, and this is how this physician has started. So your introduction will describe you. And it will set a bar that how the examiner is going to mark you. And the wrap-up in the end, it will wind up that station for you in a very nice way. If you are able to give a good wrap up to the station while leaving, it will leave a very good impact on the examiner, and it will set the bar really high for the next candidate who's coming after you. So I would suggest that you should really work hard on your introduction and your wrap up along with your history in order to score high. Okay, now, last time we discussed that after the basic history layout, you ask the questions, you narrow down your diagnosis, you ask the questions from the same set of diseases from the same system. For example, it's chest pain, so we will ask the CVS questions, and along with that, we will rule out other differential diagnoses. So we will be asking questions from the respiratory and the GI tract, and we narrow down our diagnosis. Now, this is the main, you can say a brief review of how the history of presenting illness is taken. It's a chest pain, so you always ask about onset, setting, course, position, radiation, severity, timings, impact, aggravating factors. Always have to rule out red flags and the risk factors. Now, today's class is focused on counseling. And last time we discussed how to take history. We discussed some of the questions briefly, but today's class is more focused on a counseling station. So if you are considering that the patient presents to the emergency with a chest pain and the patient, you narrow your differential diagnosis to GIRD, that the patient has GIRD, can any one of you volunteer to do the counseling of the patient? I can give you with the counseling points on the next slide. So you can use these points. Any one of you who would like to volunteer? You can just raise your hand. Just 1 minute, I cannot see the participants. Okay. You can unmute and raise your hand if you want to, if anyone wants to volunteer. And if there is no one, then I can just proceed with the points.
For example, for gastroesophageal reflux, it's better to say to the patient, you should avoid drinking tea and spicy food. Also, don't drink water between meals and something like this.
Yeah, very, very nice. These are very nice points, Nazila. And do you know that how would you like to start with the patient and how would you like to end? Would you like to contribute to that or?
After introduction ourselves to the patient, then asking about dietary habits and I don't know what exactly you mean about
So the patient is there. The scenario is like, let me go back. So because in last class we discussed this in detail. So this is the scenario that your 40-year-old male smoker comes to emergency department with chest pain, address his concerns. So if this is your patient, how would you like to, proceed with this patient?
Okay, we can give them assurance that gastroesophageal reflux isn't very important and don't worry about this problem. It can be treated by some medication and changing your habits, for example, a reduction of smoking and
yeah. These are very good points, and these are basically the points that we do in counseling. Now, let's proceed to the counseling station. Okay, so there are various types of counselings. Okay, you can choose whatever your style is and whatever you are convenient with. But for me, I feel that the conversational style of counseling is something which is very impactful for the patient as well as for the examiner in order to get you good marks, rather than just, discussing, giving a whole lecture to the patient about everything. You have to do conversational counseling. And what is conversational counseling? That you say something and the patient responds something to you. Then you ask another question, the patient responds you back. Rather than giving a 4-minute long lecture to the patient that, this is your disease, this is what you need to do. So how to, discuss all those points? Now, I use this mnemonic IBUX for counseling. I means information sharing. From B, it means brief history, understanding that what the patient is concerned about, addressing the concerns of the patient. Then you explain the disease and, whatever normal anatomy, physiology, complications management, and then you summarize or wrap up your station. So now considering this chest pain scenario that we had last time, so I will give you a brief overview that how the counseling should be done. So for example, you knock the door, you enter the room and you say, okay, knock, knock, you enter the room and I'll say, okay, good morning, I'm Dr. Umar, I'm your physician for today. How can I help you today? And you just, confirm the name and age of the patient that, okay, how would you like to be addressed? And the patient says, okay, you can call me, for example, Mr. XYZ. And you say, okay, Mr. XYZ, how can I help you today? And now the patient says, the doctor, I have this weird chest pain, and it's really bothering me. And I thought that I should come and show you. So now you see that the patient is presenting to the emergency department with the chest pain. That means that it is really something, emergent, or something that needs a quick attention. So you will ask the patient, okay, for how long have you been having this chest pain? And the patient says, well, it has been 6 months now. Now your next question should be that, okay, so what happened differently today? Like the pain is there for 6 months and now you're showing up today in the emergency department. So what brings you in? And the patient will reply to you that, well, I had a friend and, he had some chest pain and he died. He had a massive heart attack and he died. And I'm so concerned that, I might be having it as well. So now this station becomes your counseling station. You know that the patient is concerned for something. How will you address further now? So you can tell the patient, okay, I totally understand that you are concerned because your friend recently had a heart attack. So can you tell me some more about your chest pain? And then you ask all those onset and that how did it start? Where does it radiate? What makes it better? What makes it worse? After completing that set of history of presenting illness, you narrow your diagnosis, narrow down your differential diagnosis to GIRD, that, okay, this patient is having GIRD. So now you ask the patient, okay, is it the first time that you're having this pain? The patient will say, no, I had it like 2 years back when I was a student in my university and all those things. And then you can ask, okay, so you had it 2 years back as well. Did you ever get a diagnosis for this? And the patient will, yeah, I went to a doctor and he told me that I have GIRD. Okay, so were you given any medications for that? Yeah, he did start me on a pill. He asked me to take it, 30 minutes before the meals. Don't know the name of that pill? I don't remember, doctor, but it was something that I had to take, before my meals. Okay, that's fine. Okay, so now tell me that after that, taking that pill, did your symptoms get better? Yeah, they did got better a little bit. Did they ever put a camera inside your mouth and to see, that how everything is? And the patient would say, oh no, they thought that it was not required at that time. Okay, so there is another test which we just do to check the bacteria if the symptoms are not getting better. So, did you ever get tested for H. pylori? And the patient would be like, no, they said it was not required. Okay, so you were doing fine for 2 years and then this pain started 6 months back. So, can you think of anything that brought this pain for you? And the patient might say, oh, well, doctor, I don't know. I think it's just my lifestyle and it's really stressful. And I got married like, 7, 8 months back. And my wife really cooks really nice meals. And I'm a big eater. I love to eat. And then you can ask the patient, okay, so from whatever you are telling me, I feel that you're having a condition which is called GIRD. And I know that you have already heard about this term, but do you have any idea what this disease is like? And the patient might tell you, yeah, I know a little bit, or he might say that, okay, no, I don't know. Can you explain more and all that? And then you get, okay, so GIRD stands for Gastroesophageal Reflux Disease. And, in our, when we eat food, the food goes through the food canal. And when from the food pipe, when it enters the stomach, there is a gateway over there. And that gateway closes down so that the food does not come back into our esophagus. And since there are certain factors that affect the opening and closing of that gateway. And there are a lot of factors that contribute towards that. Now, why you are saying gateway for sphincter and you are saying food pipe for or food pipe for the esophagus? Because you are not supposed to use jargons. What are jargons? They are the medical terminologies. So when you're talking to your patient, you are not supposed to use any medical terminologies. It will give you it will give a very negative impact on your performance and your marks. So you have to simplify everything for the patient. So now you're telling the patient that, okay, we have a food pipe and the food goes through that. If you have your paper and pen, you can even draw it on your notebook for the patient to make them understand it better. So just tell the patient that, this is the food pipe and this is the gateway. Now, there are certain factors that, mess up with the opening and closing of this gateway. And as a result of that, all that acid which is in the stomach and the food that we eat, it comes back. And then we get all these symptoms of heartburning and chest pain. You might get even a metallic taste in your mouth. So then you can ask the patient, okay, can you walk me through a day in your life and let me know that what is your lifestyle, what you eat in an entire day, and how much exercise you do. And then the patient opens up more. He says, okay, yeah, well, I wake up early in the morning and I take a cup of black coffee, and then I don't eat for like 5, 6 hours because I feel I have gained a lot of weight. And from there, I just, I just want to lose my weight, and I'm doing kind of an intermittent fasting. And then at night, I get this, because I get so hungry, I get a very big meal and I eat that. So then you can ask the patient, okay, and how does your meal look like? What kind of spices you use? And the patient might say, I use spicy kind of food, and it's oily and it's very good, and I'm a foodie and all that. So you tell the patient now that, okay, so there are various factors that are contributing towards this condition, and this condition is manageable. And how we can manage that? We can do it in two ways. There are lifestyle modifications, and then there are some medications. And if you don't get better with these two, we can proceed further to some more investigations. So let's talk about the lifestyle modifications first. And then you ask the patient, okay, so you told me that you wake up in the morning and you just drink coffee, empty stomach. So coffee is a big contributor towards this making these symptoms worse. And the patient would be like, oh, really? Okay. So what should I do then? So you tell the patient that instead of having one large meal before your bedtime, why don't you just divide your meals in several portions throughout the day? Take small meals throughout the day. At the end of the day, try not to take very spicy and oily foods. Go for a lighter snack. And your last meal should be at least 2 to 3 hours before your bedtime. Just don't go directly to your bed after eating. And uh, when you are in the bed, try to raise the head end of your bed. If you're using one pillow, try to take two pillows. And then you ask the patient that, okay, other than that, how much exercise you do in the entire day? And the patient might say that, I don't get to do any exercise, or I do exercise for a few days. So just tell the patient that, I would really like you to have almost 150 minutes of exercise in a week. That is how it is recommended according to the Canadian guidelines, and it will be very helpful for you. Now, the patient might say, oh, I have a very busy lifestyle, doctor. I work night and day shifts. You don't know how difficult it is to make your ends meet and all that. And then you tell the patient, yeah, yeah, I do understand. And I know it's a very busy life. We are all, really struggling to make our ends meet, but at the same time we have to prioritize ourselves. So I can see that you have gained some weight. Do you think that you need any help in that regard? And the patient might say, oh yeah, doctor, I do think that I need to have some help in that regard. So you can tell the patient, okay, so I would like to set up a follow-up appointment with you to discuss the means by which we can reduce weight. And then you tell the patient, another risk factor that I see is that you are smoking as well. And, smoking also contributes not just to this GERD related chest pain, but it is also a risk factor for heart related chest pains. So whenever you're ready, would you like to set up a follow-up appointment with me to discuss your smoking cessation? And the patient might tell you, oh yeah, or he might say, no, I'm not ready for that yet, And then after that, you have given him a brief review of what GERD is and how everything works. And after that, now you ask the patient that, okay, so since we have discussed all this in detail, but because you are concerned that your friend had a chest pain and he died because of that, so just to make sure that everything is okay, because you are smoking and it is a risk factor for developing the heart-related chest pain, I would still like to do some investigations. I would like to run an ECG for you and do some investigations, and I will be doing a physical exam for you. And the patient might say, okay, doctor, thank you so much and all that. And then you discuss about the red flags. You tell the patient, okay, in case this pain ever gets worse, in case you feel that your stool is getting darker, or you're vomiting some blood, or you feel that the chest pain has changed in the way it is right now, or changed in frequency and nothing is making it better, please come back to the emergency department. Okay, so this is how you are telling the patient about the red flags as well, and you are addressing their concerns as well. And then you tell them that, okay, these are the lifestyle modifications that we discussed. Other than that, there are some medications available, and you have already used one of them. So they are called proton pump inhibitors. And the mechanism of those medications is that they stop the production of acid before the food reaches it. So that's why we can start you on those medications. And after 1 month, I would like to set up a follow-up appointment with you just to see that how your sign and symptoms are. And if it doesn't get better, then we can do some further investigations. Now, the patient might say that, doctor, I think this medication helps me and I'm traveling somewhere, so I would like to use it for 5 6 months and all that. So you tell the patient that, yeah, you can use it for 5 to 6 months, but let me tell you that because they control the acid of your stomach, so sometimes some of the important vitamins, they are not absorbed the way they are supposed to, and you might develop some tingling and numbness in your hands. So I would suggest that please try to come back in a month. And these medications can be used as needed as well. Whenever your symptoms get worse, you can use them. So all these points, this is how you're going to discuss with the patient, and then you tell the patient, okay, I will see you in 1 month or 6 months. You set up a follow-up appointment, and you tell the patient, if you ever feel you need to come back earlier, please feel free to contact me. And this is how you wrap up. And then in the end, you ask, are there any other concerns that you would like me to address today? And the patient might say, no, that's fine, I'm good and all that. So this is a brief review or a brief glance of how you weave your thread around the counseling station. Any questions so far? Okay, no questions. So we can go ahead to the next slide. So this is how counseling is done in a counseling session, and GIRD is relatively a very easy topic to deal with. There are other topics, like there's a whole list of counseling topics which are in NAC OSCE that you need to prepare and you need to have very crisp information about. In the next few slides, I will be discussing the details of the course that I'm offering, and after that, we will proceed to the next topic of the presentation. So these are the details for the boot camp. Starting date is January. January 26th to all the way till February 26th. And after the last class, I got a very overwhelming response. Thank you very much for that. And some of you requested that, they're not available on the weekdays, and if I can host the classes on the weekends. So now I will be running 2 batches, one on the weekend mornings and the other one on the weekday mornings. The days would be probably will be Tuesdays and Thursdays on the weekdays, and weekends, as you know, that's Saturday and Friday. Timings will be 9:30 to 12:30, and it will be 2 days a week, and fees for the entire course is 400 Canadian dollars for 2 months per person. And I plan to cover 140 to 160 high yield questions. Number of students in each batch will approximately be 12. I don't like very big batch because I feel that everybody does not get a chance to participate and practice their questions. So I think with a smaller batch, we can be more productive. That's the reason that I have divided the classes into 2 batches. And these are the units that I will be covering throughout. There will be 16 classes. And as you can see that this is the breakdown of all the units that we'll be going through: GI, then respiratory, cardio, Uro, Nephro, Neuro, MSK, Endo, Peds, Obs, Gynae, and Psychiatry. These are the topics that I will be covering from the cardio. This is not the final list. I might add or subtract a few topics from here and there, but these are the cardio topics, almost 15 topics from cardio, 7 topics from respiratory. And from GI, we have almost 18 topics. This is from Nephro and Uro, almost 7 topics. MSK, almost 11 topics. Neuro, almost 14 topics. From rheumatology, 7 topics. And there are some miscellaneous topics, which are, from here, different systems here and there. Then we have Obs, Gynae, 12 topics from there. 16 topics from Peds. and then 9 topics from psychiatry. So this is the brief overview. You can reach me out at medicinebyheart@gmail.com, and below is the link for the Telegram channel. Any questions so far before we proceed to the next half of the presentation? You can just unmute yourself if you have any questions. Okay, so no questions so far. Okay, so now this
no, everything was perfect, Dr. Sana. Thank you so much.
Thank you.
Just I have a short question.
Yeah.
So I wanted to know if you are providing any notes, like any notes or any something like printed notes to participants or not.
For today, you mean for today's session or for the boot camp?
No, not for today at all. I mean, are you sharing
Yeah, for the boot camp. Yeah, for the
your
boot camp.
group with the participants?
Yeah. Yes, for the boot camp, I have designed the entire course. Everything is written. I will be sharing all the slides, even the counseling that I just discussed verbally. It will be written in written form. And there is one more thing that I would like to do with my students, and that would be that I will be audio recording these sessions, and then I will transcript it. And after transcribing it, I will be sending, after each completion of each unit, I will be sending that transcribed script to the students as well, so that they know that how the questions were proceeded in the class, and what were their answers, and what are the areas where they need to focus. So this is for the boot camp, that each and every, all the topics that I've mentioned here, I have made slides for them. All the slides will have the details, how to ask the questions, how to address anything, a list of differential diagnosis, a list of post-encounter questions. So all that is a part of the boot camp. So you will be getting a lifetime access to everything. I will be sharing all the slides and everything with everyone. And if any of my students, for example, if someone is taking one session, if they think that they need more practice, they will be more than welcome to join my other session, which will be ongoing as well. For example, if you are taking a class on the weekend, you can and you think that you need to review that system once again, you can go back and come back on the weekday class and review that session. And apart from that, you will have your own slides. After I'm done with doing one system, I will be sending the slides and everything for that particular system, and the related questions and the scenarios and all the explanations. Yes. Okay, so let me see. There is some question in the chat as you're welcome. I cannot see my chat here. Just one second. Let me check the chat.
Okay, Dr. Sana, they are asking about what are the topics in OB-GYN in the chat.
Oh, you know, okay, I'll go back to the slide. Okay. So these are the OBS-GYN topics: vaginal discharge, vaginal bleeding, amenorrhea, infertility, OCP, antenatal counseling, genetic counseling, abortions, preeclampsia, C-section, HRT, and pap smear. There are a few topics that I was working on last night, which was pre-diabetes counseling, etc. So I might add that also to this set of questions. But these are the main topics that I will be covering in OBS-GYN. And all these topics, I will try to do them in 2 ways. One is that because all the stations can be, any station can be counseling station, any station can be a post-encounter and physical exam. So we will try to do all these topics in the same way. That if it comes as a counseling station, how will you do that? And if it comes as a normal station with physical exam and all that, so how are you going to proceed with that? Any other questions in the chat box?
Yeah, the other question is that do you provide sample checklist while practicing?
Sorry, sorry, I can see the chart now. Let me open it. Do you provide sample checklist while practicing? Yes. You mean by checklist, do you mean that like the checklist of like how you're doing the station, or you want a marking list? What do you mean by checklist? If you can unmute or just let me know. Marking list. Oh yeah, I have a marking template with me, and for that marking template, after whenever we are studying in the class, so how it will work is that first we will be discussing the topic, okay, the cluster of symptoms and what questions are to be asked in that system, and after that we will be practicing some questions, and the student who will be practicing that question, I will be marking on the sample. I have different sections marked there, which have different points according to the NAC OSCE breakdown, the way they send it in Physicians Apply. So I have the breakdown in that form, and there will be different marks for counseling. It will be, you will be assessed on your communication skills, your body language, your questions, and your time management, and your empathy towards the patient. So yes, I will be providing a checklist as well of your performance, that how you have performed in that particular section. Okay. Topics in the respiratory system. Yes, sure, I can go back. Somebody said, did you get NAC OSCE? You mean I passed NAC OSCE? Is that the question? If yes, yes, I did pass my NAC OSCE. And
when did you?
Oh, okay. So I passed my NAC OSCE in 2022. And I was able to get very good marks. I had 2 standard deviations above the mean. So yeah. And last year I also did a small discussion of mentorship with one of the institutes here. Okay. So I will show you the respiratory system. Anything else? No, nothing else here. Okay. I'll go back to the presentation now. Yeah, these are the respiratory topics. So we'll be discussing asthma, that how you deal with the case of new onset of asthma, how you follow up if a patient is coming with the previous asthma or an attack, so how you follow up with them, COPD exacerbation, then pneumonia, PCP, cancer, and tuberculosis. These are the main high yield topics that NAC OSCE questions are built around them. So yes, this is for the respiratory system. Okay. So yeah, that's pretty much it. No questions. Okay, now let's proceed to the next half of the presentation. So till now we were discussing NAC OSCE oriented question and answers, and how to address a counseling session in NAC OSCE. The next half of the presentation is more directed towards QE1, and for NAC OSCE participants, it's valuable because it can help you with the post-encounter questions. So today, I will be discussing some of the psychotic disorders with you guys. And, the term schizo by itself, it's like an umbrella term. And there are so many things that come under it: schizophrenia, schizophreniform, schizoaffective, schizoid, schizotypal. So all these terms are very confusing for the students. So my today's presentation is based on the term schizo and the related diagnosis with it. So under the umbrella of the term schizo, we have 4 psychotic disorders, okay, which are brief psychotic, schizophreniform, schizophrenia, and schizoaffective. And 2 of them, schizotypal and schizoid, these are personality disorders. These are not psychotic disorders. What does that mean? That the patients with these personality disorders, they have issues with their personalities, but they don't have any sign and symptoms of psychosis. Like they don't have delusions, they don't have hallucinations. So these 2 things, schizotypal and schizoid personalities, they are personalities. But these 4 forms, brief psychotic, schizophreniform, schizophrenia, and schizoaffective, these are the terms that actually come for psychosis. And all of them have some differentiating points. What is brief psychotic? Brief psychotic is when your sign and symptoms are for a brief period of time, and we will discuss those durations in the next slide. What is schizophreniform? Schizophreniform is that you have the same set of signs and symptoms, delusions, hallucinations, or any one of them, but the time duration is 1 to 6 months. Okay. Then you have schizophrenia. Anything which goes beyond 6 months, that is your schizophrenia. And then you have schizoaffective disorder. What is schizoaffective? It means that it is a combination of schizophrenia, and there is a component of mood disorder with that. It can be either depression or bipolar. And whatever sign and symptoms you see first, that becomes, for example, it becomes major schizoaffective disorder with major depressive disorder. So that becomes your diagnosis. Now, when we go to this is the personality disorder. So schizotypal and schizoid means that the patient will not have delusions or hallucinations, but they have the other symptoms, sign and symptoms from their personality. For example, they will be loners, they will be people who don't like to interact with other people. So who are schizoid personalities? Schizoid personalities are the people who have failed relationships. They don't like to interact with the people. They are socially detached. They will, go for nighttime jobs. They would prefer that they work in a jungle or somewhere where they don't have to interact with other people. And the thing is that they are very satisfied in their own world. They don't feel the need to interact with other people and to talk to them. So your whatever question stems you will get, they will be pointing out towards all these things. Schizotypal, on the other hand, they have very eccentric and magical thoughts, aloof dressing. For example, even if the weather is really hot outside, they will be wearing 3 layers of shirts. Okay, and their thinking will be very magical, and they will be giving you some vague thoughts. If you're talking to them, they will give you answers that you will say that, oh, this doesn't even exist. What kind of a world this person is living in? And the thing which is important about schizotypal is that this is the malignant form. That means that it has a very high chance of turning into schizophrenia if it is not treated or if it does not get better. So schizotypals, they can proceed to schizophrenia. Now, one thing in psychiatry is very important, that is the time duration. Time duration is very, very important when it comes to psychiatric patients and their diagnosis. So in other, set of questions and in other systems, you go for sign and symptoms first. But for psychiatry, you actually first go for the time duration, because that is something that will define your diagnosis. So now when it comes to schizophrenia, sorry. Okay, so this is a timeline to differentiate different psychotic disorders. As you can see that this graph, the horizontal line shows your time in months and the vertical line shows your diagnosis. For example, anything which is between 0 to 1 month, that means that all the signs, symptoms resolve within 1 month, or they are just there between 0 to 1 month and then they're gone. It is called your brief psychotic disorder. Anything which extends from 0 to 6 months, it goes beyond that 1 month and goes all the way up to 6 months. But after 6 months, the patient feels better, it is gone. That is called just schizophreniform. Okay. And the next set of symptoms are, once it crosses the line of that 6 months, it leads to schizophrenia. Then you make the diagnosis of schizophrenia. Now, what are the sign and symptoms that we are talking about? What sign and symptoms need to be there in order to, make these diagnoses? So schizophrenia is a combination of 3 types of symptoms: positive symptoms, negative symptoms, and your cognitive impairment or cognitive symptoms. What are positive symptoms? Positive symptoms means that the new features, okay, new features that don't have a normal physiological component. For example, as human beings, normally we don't have delusions, we don't have hallucinations. So this is something which is newly introduced to our system or to our body. This is called a positive symptom. So that can be delusion, hallucination, disorganized speech, catatonia. What are delusions? Delusions are very strong false beliefs that are not based in reality. That means that the patient has very fixed false belief that no, something is there and they will not change their thought process about it. That is a delusion. And what are hallucinations? Hallucinations are the actual things that they see, the perceptual experience that they have, and there is no external stimuli for that, okay? It can be auditory, it can be visual. For example, the patient can just say that, this newscaster is just talking to me right now. This is a visual hallucination, that the newscaster is giving information about something else, and the patient is like, oh no, this is talking to me, and they are giving me the instructions. Or for example, if they are just thinking and they are like, the aliens have invaded the earth, and I need to go and fight them off. So these are all their hallucinations and their delusions. Other than that, they might have disorganized speech, which means that you ask them a question, and instead of giving a straight answer, they will give you a word salad. They might also have, the disorganized behavior, purposeless actions, wearing multiple layers of clothes. Other than that, catatonia means that it's abnormal motor behaviors, immobility, or excessive movement. Now, all these are the positive symptoms. What are the negative symptoms? Negative symptoms are that, negative symptoms are that there is a reduction or loss of normal functions. That means that those functions are already there in the body. We as human beings are already doing all that. And slowly and gradually, you start losing that, okay? You start losing that thing. This is called your negative symptom. For example, flat affect. A normal human being is talking with good emotional expressions, and all of a sudden, the person starts to become emotionless and stops, stops expressing their happiness or their sadness or whatever to their people around them. So these are the negative symptoms, that the systems which were already running in the body, there is a regression in that. They have started to fall down. Then it has evolution. Evolution is that they just, lose the purpose, the motivation to do anything. Elogia, which means that their speech becomes very poor. They are short of words. Then anhedonia, that is that inability to, experience pleasure in previously enjoyable activities. That means that they're not enjoying the things that they were doing earlier. And then slowly and gradually, they start to withdraw themselves socially. They prefer isolation, they prefer staying alone, and they prefer, not mingling with people. So these are the negative symptoms. Third is the cognitive impairment. What is cognitive symptoms? It means that your cognitive function, the thought process, your understanding, that is at a stake now. Okay, so now you will have difficulty in retaining information. You will be unable to focus on your tasks. You will have very poor executive function. That is, you will lack your planning, organization, and all those things. So schizophrenia is a combination of these three things. But what symptoms have to be there according to the DSM-5 criteria that will give you the diagnosis that, oh, this is schizophrenia or schizophreniform or brief psychotic disorder. So at least 2 or more of the symptoms should be present, at least for a duration of 1 month, okay? And one of those symptoms should be either delusions or hallucinations or disorganized speech. So these three top things, delusions, hallucinations, and disorganized speech, which are a part of your positive symptoms, even if one of that is present for a continuous duration of 1 month and for more than 6 months duration, then in that case, you label it as schizophrenia. Now, let's suppose that all these symptoms, or even one of them, like delusions or hallucinations, anything, even one of that sign or symptom that is present for 1 month. What it would be then in that case? It will turn into a brief psychotic disorder. If these symptoms proceed from 1 month to 6 months, and then the patient says, oh yeah, I got better after that, and I never had to experience that again, that is schizophreniform. But the moment it crosses that timeline of 6 months, for example, the patient comes to you that for a year he's having all delusions and hallucinations, he gets it for a month, then it stops, and he gets it again, or he gets it for 6 months in one duration, you make the diagnosis of schizophrenia. And what is important in this, that you have to rule out that it is not because of substance abuse. There is no organic cause for that. And the patient is not having any other disease. So in that case, you make this diagnosis of schizophrenia. So the core symptoms are 3 core symptoms you have to remember: delusions, hallucinations, and disorganized speech. Even if one of them is present there, and it is for more than 6 months, it falls in the criteria of schizophrenia. Okay, so the social occupational dysfunction and all this is just for, you know, a quick read, but to solve the questions in QE1, you just need to remember these two things, that delusions, hallucinations, and your disorganized speech, if any one of them is present, duration is more than 6 months, there is no history of any alcohol, drug abuse, anything, just go straight away for schizophrenia. So this part, social occupational dysfunction, it is just for, you know, for your background knowledge, something that should be kept in the background of your brain. And as I mentioned, that we have to exclude other disorders, that there is no substance abuse and nothing. In NAC OSCE, this is more, you know, I would say that relatable to NAC OSCE, because in NAC OSCE, you have to rule out all the organic symptoms and drugs and everything. But from QE1 point of view, or QE1's perspective, if you know the time duration and you know the DSM-5 criteria, that what is the main thing that you're looking for, just go for that in the question stem and you make your diagnosis quickly. Okay. One thing which is important is that if a patient has a history of autism spectrum disorder, okay, in that case, schizophrenia is diagnosed only if prominent delusions or hallucinations are present for at least 1 month, okay, or less if treated, other than other symptoms. Now, what is the treatment of schizophrenia? So it's a multi-dimensional approach when it comes to treatment of schizophrenia, because it is a syndrome. What is a syndrome? A syndrome which has an umbrella. It is like an umbrella. It has multiple symptoms and signs. So schizophrenia is just like that. So for every syndrome, we have a multidisciplinary approach, multi-dimensional approach. We have to have other, you have to include other specialities as well. So it is multidimensional. It involves medications, it involves psychotherapy, it involves psychosocial interventions, and then it also involves, you know, your family, and you have to have family counseling to make them understand what the patient is going through. So what is the pharmacological treatment? Okay, you can either have first generation antipsychotics. I've just given a few examples here. For example, haloperidol and chlorpromazine. They are D2 receptor antagonist, and they're mostly their side effects are extrapyramidal side effects and tardive dyskinesia. Now, all these drugs, they are to be studied in detail. I'm just giving you a brief overview. You need to know the signs, symptoms of the disease, and then for that particular patient, what drug will you go with? It depends upon the comorbid conditions of the patient, that if the patient is having some other, you know, problems going on with that, for example, not eating well, or the patient is not able to sleep, or patient has diabetes, so then you just, you know, move your medications here and there. But this is the basic set of medications. Antipsychotic medications, first line of first generation antipsychotics. Then if you fail with the first generation, you go for the second generation antipsychotics, which are risperidone, olanzapine, quetiapine, aripiprazole, and they are dopamine and serotonin receptor antagonists, like they block both the receptors. Their advantages are that their extrapyramidal sign symptoms are less as compared to the typical antipsychotics, but they have metabolic side effects. And then all of them, when we study the drugs in detail, we know that all of them have different effect on, you know, intensity of effect on the metabolic syndrome. Olanzapine contributes a lot towards metabolic syndrome, so we will avoid it in patients who are already obese or diabetic and stuff like that. The next is clozapine. Now, what is the importance of clozapine, especially from the exam point of view? That clozapine is given for resistant schizophrenia. Resistant schizophrenia means that you have failed 2 treatments. 2 times you started the patient on this medication, and the patient still comes back with signs and symptoms of schizophrenia. Then for the treatment of that resistant schizophrenia, you go for clozapine. So this point is very important when it comes to the exam. It is very frequently asked in exam questions. So always remember, resistant schizophrenia, go for clozapine. Okay. And what is one thing that you always have to remember with clozapine, agranulocytosis, that it requires regular monitoring for agranulocytosis. So it leads to, because it can lead to, you know, low blood count and everything. When I was studying, so with clozapine, I had replaced O with the heart. So that means that, you know, I have to do, it affects the heart, and you have to look for agranulocytosis in that. And with olanzapine, I always used to remember that it's an O. So O is like a donut. So the patient, it will make the sign and symptoms and of diabetes worse for the patient, and it will contribute towards the metabolic disorder. Okay. Next, we have psychosocial interventions for the treatment of schizophrenia that involve your CBT, your family therapy, social skills training, supported employment programs. Now, why this is important? Because sometimes in QE1 questions, they will give you everything that, okay, the patient came to us, we started the patient on haloperidol or clozapine or whatever, and we also did the blood work for the patient. Now, what will be your next best step? And then they give you all these things. So you have to choose from this. So at the back of your mind, you should know that these interventions are also one of the treatment options which come under the umbrella of treatment of the schizophrenia. When do we hospitalize a schizophrenic patient? When it is an acute psychotic episode, when there is a risk of harm to oneself, inability to care for oneself. And what is the advantage of hospitalizing the patient? Because it gives the structured and a more stable environment. In every psychiatric question, always rule out suicidal ideation. That is the first step. The moment the patient is free of suicidal ideation, then you can proceed, with the patient. But once you have not ruled out suicidal ideation, that is a very big red flag. Because the examiner will have the idea that this is not a safe doctor. You can do everything for the patient, but if you have not ruled out suicidal thoughts, you are in big trouble. Other than that, there are some, a few other interventions like ECT, electroconvulsive therapy. You should know that this exists for schizophrenic patients, and it is reserved for very severe kind of, treatment-resistant cases. Other than that, catatonia and for depressive features. Then the last thing is long-acting injectable antipsychotics, and they are used for non-adherent patients. And I have given some of the examples of those medications. So always remember this thing that you should know the main treatment, but other than that, you should also know all these treatments because you will be, because you can be tested. The examiner will not ask you a very straight question. They will go around in circles. So they might give you the easy ones by themselves, and they will ask you to, tell them the next possible step. You have to address the comorbidities of the patient as well. And this is particularly important when it comes to NAC OSCE as well, because when the patient mentions that, they are using any substance, like when we were just doing the counseling for GIRD, if any one of you can remember that I did tell the patient that since you're obese and you're smoking, I would like to set up a follow-up appointment with you. So this is how you address the comorbidities. Sometimes in even QE1, they might do a question in which they have done everything for you and for the patient. The question might have a long stem that, okay, the patient had schizophrenia, the patient was given this, and they will give you a brief history. And then they will ask you, what will you do next? And your answer would be that I would like to, rule out a substance use disorder or follow up an appointment to discuss drug addiction. So you should know all these steps, okay, at the back of your mind, because this is how QE1 questions are intervened. They will not give you something very simple. Simple things are there as well, of course, but some of the questions which are very easy and everybody knows the answer, they usually twist them around like this, that they give you the easier part and they leave the difficult part for you. Okay, what is the maintenance and long-term care of schizophrenia? So we continue medication for 1 to 2 years after the first episode. So if the exam scenario tells you that it was the first episode, you go for at least 2 years. But if there are multiple episodes or there is a previous history of hospitalizations due to psychosis or anything, then the treatment is lifelong. Okay, other than that, we always provide regular follow-up and monitoring for these patients. Sometimes they might give you the name of the drug in the question stem and ask you that what would be your best next step. So, you have to choose metabolic profile or regular follow-up or check for agranulocytosis and all that. Then you have lifestyle modifications, you have stress management through mindful techniques, you tell them to have a balanced diet, regular physical activity. What is the prognosis of schizophrenia? So it has a 1/3 rule. That means that 1/3 improve, 1/3 have residual symptoms, and 1/3 remain severely impaired. So this rule of 3 is important when it comes to your questions. They can ask you that, okay, the patient comes to you and asks you about the prognosis of their disease. So how will you address that? So this point of view is important in that regard. Now let's practice a few scenarios together. A 25-year-old man presents with a history of social withdrawal, poor academic performance, and strange, sorry, where I was admitting someone in the meeting. Yeah. So poor academic performance and strange beliefs over the past year. He reports that hearing voices commenting on his actions and believes his thoughts are being broadcasted to others. He has become increasingly isolated and exhibits flat affect during the interview. Physical examination is unremarkable and there is no history of substance use or medical conditions. What is the most likely diagnosis? Now, what do you think is the most likely diagnosis? Anyone who would like to volunteer and unmute themselves, or you can just write in the chat box, whatever is easy for you. Okay, some of you are writing D and okay. Okay, so we've gotten a number of responses. Now let's dissect this case. Let's go to the question stem again. 25-year-old man, history of social withdrawal. Okay, so the patient is regressing. This is the negative symptom that we discussed. Social withdrawal, poor academic performance, okay, and other of the negative symptoms that he's declining in his academics. Strange beliefs are it can be delusions because they are beliefs over, what is the time duration? Past year, 1 year. So it has crossed that 6 months duration time. He reports hearing voices commenting on his actions and believes his thoughts are being broadcasted to others. What is this? This is a hallucination that he's having. He has become increasingly isolated and exhibits flat affect during the interview. When you're talking to the patient has a flat affect. What is a flat affect? Another of the negative symptoms. So the patient is having a combination of positive and negative symptoms. Now, the duration is for more than 1 year. That means that the patient is falling in the time zone of schizophrenia because it is more than 6 months. Now, let's see that because it is more than 6 months, what is the DSM-5 criteria that we need to diagnose him as schizophrenia? That is either of the delusions or hallucinations or the disorganized speech. And what is this patient having? This patient is having, let me use my, pointer. So what is this patient having? This patient over here is having poor academic performance. It is a negative symptom. It is not the DSM-5 exact, like it should be a part of it, but the main criteria, what is that? That is this one, hearing voices, commenting on his actions. This is hallucination. So this makes our diagnosis of schizophrenia more relevant to this question. And as we all know that what is it? Schizophrenia, it is a combination of positive, negative, and cognitive impairment symptoms. So this is how the diagnosis of schizophrenia will be made in this particular scenario. Now let's go to the next question and see what do we have there. And one more thing, as I mentioned earlier, that we always have to rule out any organic causes in psychiatric stations from NAC OSCE point of view, as well as from QE1 point of view. Even, if you don't rule out an organic cause, the first step is that you rule out the organic cause, then you can proceed to the psychiatric differential diagnosis. So in this case, there is no history, no evidence of substance use or medical conditions or, any mood symptoms which are dominating the clinical picture. So this is schizophrenia. Next is 30-year-old woman presents to the emergency department after experiencing visual hallucinations and paranoid delusions for the past 5 days. What is the time duration? 5 days. She believes she is being watched through hidden cameras in her home. These symptoms began shortly after a major argument with her partner. Her mental status examination shows heightened anxiety, disorganized thought, and no insight into her condition. There is no prior psychiatric history. Her symptoms completely resolve within 2 weeks without further intervention. What is the most likely diagnosis? Any one of you would like to write in the chat box what is the most likely diagnosis? Yes, very good. Brief psychotic, exactly. Because, yeah. Thank you for your responses. So the symptoms are for 1 day, okay, but they lasted for less than 1 month. and the patient has eventually returned to the to her initial state, like it lasted for 1 month. And usually for brief psychotic disorder, there is usually a traumatic event or something that can bring that on as well. So she had a major argument with her partner. That is another symptoms. So this patient meets the DSM-5 criteria for brief psychotic disorder because it's a new sudden onset of psychotic symptoms. It is after a stressor, and the duration is short, that is less than 1 month. And then there is complete resolution of reoccurrence. They might not give you everything in the question stamp. Like I have made an elaborated question stamp just so that you can remember all the sign symptoms. They might give you a few of them in a QE1 exam, but you should be focused on the delusions, hallucinations part, and other than that, the time duration. So it will help you to reach your diagnosis. Okay, let's go to the next question. Okay. So this is a 35-year-old man presents with a history of avoiding social interactions and preferring solitary activities. He describes having little interest in forming close relationships, including with family, and denies any significant emotional expression or desire for companionship. He works independently and finds satisfaction in solitary hobbies. He denies hallucinations, delusions, or mood disturbances. There is no history of substance use or significant medical conditions. What is the most likely diagnosis? So can any of you write in the chat boxes, or you can just unmute yourself? Yes, exactly. Okay, so what is this? This is a schizoid personality disorder. Well, how come it's a schizoid or schizoid personality disorder? What makes it this one and not avoidant or schizotypal or what? Because this person is very clearly denying the, yes, loner, exactly. Thank you for their answers. So this is a person who's a loner, who has little interest in, having close relationships, and he denies, and he doesn't feel the need of having, any companion. If it was schizotypal, they would have added that the person has a magical thinking, or he has dressed up in an aloof way, which is not making any sense to you. For example, he's coming to see you, but the patient is dressed up in a very abnormal way. So this question stamp, it relates more to the schizoid personality disorder. Why other personality disorders cannot be there? What is avoidant? Avoidant is that avoidant personality also involves social withdrawal, but that social withdrawal is because they have the fear of rejection or criticism. They are fearful that somebody will criticize me, or they will reject my proposal, or reject my presentation, or reject me for something. So they avoid being on those situations. That is the avoidant personality. Schizotypal, as I already mentioned, that odd beliefs, magical thinking. What is major depression? Major depression is when it's a whole criteria of major depression. So when we will study that part, it's MCG caps and the mnemonic, and there's a whole criteria, different criteria. Social anxiety is that when it comes with social, phenomena and situations. So this is something which points more towards schizoid personality disorder. Okay, let's go to the next one. Okay, so 28-year-old man presents with episodes of depressed mood, lack of energy, feeling of hopelessness lasting for several weeks. During these episodes, he also reports hearing voices, commenting on his actions, and believing that others are conspiring against him. At other times, he experiences elevated mood, with increased energy, decreased need for sleep, and grandiose ideas. His psychotic symptoms persist even when his mood is stable. There is no history of substance use or significant medical conditions. What is the most likely diagnosis? So what do you think is the diagnosis in this case? Okay, so we are getting some responses. Yes, B, schizoaffective. And how does this become schizoaffective? Because schizoaffective is something which is a combination of your mood symptoms. It can be depression or mania. With depression or mania, the patient can have psychotic symptoms, that is delusions and hallucinations. So the key diagnostic feature is that psychotic symptoms like hearing voices, etc., they are for at least 2 weeks outside of the mood symptoms. What does that mean? That means that he has depressed mood, he has lack of energy, feeling of hopelessness. These are all mood symptoms, okay? So these mood symptoms, and other than that, hallucinations and delusions for 2 months. So it's a combination now. This points more towards schizoaffective disorder. So and for the others, as you all know, schizophrenia, the time duration is different. Okay, for bipolar 1, there is a different criteria. For major depression, there is another criteria, and that we will discuss later. And brief psychotic, as we all know, that it's for under 1 month. So this is how it is. There's a question in the chat. Let me see the chat. How to differentiate between B and C? Okay, let's talk about that. Sorry, I can minimize it. Yeah. Okay, so what is B? B is schizoaffective. Okay. And sorry, what B and C did you say? Let me see that again. Yeah, B and C. Okay. So C is bipolar 1 disorder with psychotic features. Okay. What is bipolar? Do you have any idea what is bipolar disorder? Okay, so bipolar 1 is when there is at least one episode of mania. Okay. One episode of mania means even if the patient is having anything, any mood disorder, anything, but there is a history of one symptom of mania or one episode of mania, we diagnose that patient as bipolar 1. Okay. So in this patient, there is no mentioning of mania. What is mania? That the patient is full of energy and the patient is running around here and there and presenting you with multiple ideas, or coming to you that telling you that I drank so much last night and I have been working for 3 days on some assignment. I'm designing a new warfare, or I have a meeting with the president. So that is a manic patient. In this entire scenario, we have the mood symptom, the depression, but we do not have any mania. He just believes that, hearing voices, commenting on his actions, this is hallucination. At other times, he experiences elevated mood with increased energy, and decreased need for sleep. What is this? This is mood symptom. Grandiose ideas are there, but this is not something which is, it can be something like, what I can say, a hypomania that he's experiencing, but it is not hypermania. So for bipolar 1, we need one episode of mania at least to do that. So this is more pointing out towards schizoaffective disorder, that delusions, hallucinations, and some mood symptoms here and there. I hope I'm able to address your question. Okay. So that was pretty much from my side for today. Are there any questions and clarifications that you guys need? I would be more than happy to answer. Okay, we have some questions in the chat box. Increase energy and decrease sleeping isn't mania. Okay, so yeah. So, when it comes to depression, because this today's presentation was not on depression. So there are two types of depressions. Depression can be typical and it can be atypical. Typical depression is when you have low energy, low appetite, all the SIGI cap symptoms, everything is low. Okay, your mood is low, your energy is low, your appetite is low. Atypical depression, on the other hand, is when the patient is sleeping more and the patient is the patient is sleeping more and the patient is eating more. That is the atypical one. So this increased energy is more, and this decrease in sleeping pattern, this is more pointing out towards depression, considering this scenario. If it's a manic episode, for mania, you need to have, the dig fast. The mnemonic for mania is dig fast, in which the patient is distractible, impulsive, and grandiose ideas. So that is what points out towards this question to be more aligned with this schizoaffective disorder, other than making it a bipolar 1. Bipolar 1 will have a more aggressive picture. Yeah, thank you. I hope I'm able to answer the questions. You're welcome. So any questions? Anyone have any questions? Or anyone who would like me to repeat anything? Okay, Thank you very much. Thank you very much, Rajan. Yeah. So like today's presentation was just a brief review of everything. If any one of you would be interested in reaching out to me for the NAC bootcamp, I will be posting the details on the Telegram channel as well today. And if there is anything else that you guys need to ask, just reach out to me at medicinebyheart@gmail.com, and this is the link to the Telegram channel. Thank you very much for your time, everyone, and we'll see you again. Thank you. Have a good day.